not your lateral or your central, just the canine and back. Okay. Good question though, thank you for bringing that. That would be a really mean trick question.
Yeah, it would.
Okay, so we're going to review some of these together. We have, so here's a carious lesion here. It looks like it's, where is this surface? Class 5, yep, because it's along the buccal or lingual surface. It can be on an anterior or posterior tooth, and this is what it will look like in the mouth. Okay. Okay, you're all too smart. Okay, how about this one? Class 1, right? Occlusal or including that buccal bit. What about this one? Class 6. You can see how it'd be kind of hard to, you know, because it's such a cleansable area, you know, that's just, something just didn't form right there. What about this one? Class 4, because it includes that incisal ledge. And that's what it looks like on radar. That looks like it just got, like, chopped off.
I feel like they look like 4s. Like the 4 has like a chop off.
Hey, good.
That's the only way I remember.
Down here, and then 4. Thanks, Thanks, good. And what about this one? So not including the incisal edge, but it is on an anterior 3. Very good. And what about this one? 2. So it's on a premolar. Or it can be on a molar, and that's what it looks like radiographically. What's this right here? There's some demineralization going on there. Even a little bit starting right there, a little incipient lesion starting there.
How, I don't see how you can see that one. All the others are like, yeah, okay. But that
Right
one
here?
is like, yeah.
It's just barely starting to fade out. Look at the difference between this surface and the mesial surface here. See how that's a nice crisp white line? And right here, it just fades just a hair.
Would it be right across as well? It looks like it's a little bit darker there.
Here?
I see the one across
Yeah,
from
this
it.
one looks a little
Right
more
there,
obvious.
yeah.
Yeah, this one may actually be through that DJ there. So, yeah, good. See, your trained eyes. You're getting them. Very good. Okay, so let's talk about some selective care planning for the patients that do have some lesions that we need to worry about. So you want to plan for restorations if there is existing lesions. So I did want to point out in the beginning that I forgot to mention, we kind of touched on how it's important for the hygienist to have a background in caries. When I was first out of hygiene school and I moved up from St. George up to here, I was temping in a lot of offices and I was trying to find work, and I ended up temping for an office whose hygienist was out on surgery. So he was using a whole bunch of temps, and I ended up working for him, and I still work for him 14 years later. And I asked him, what was it that you gave me the job? And he's, besides my charming personality, was that I was trained by my previous doctor. I worked for a year out of hygiene school for a doctor that pretty much had the hygienist do the exams. And legally we can't diagnose, but we would go through and we would find everything. We'd use the diagonate, we'd use the intraoral camera, we would show the patients everything, talk to them about what restoration they were probably going to expect with that type of lesion. So that the doctor came in, he was very, very busy, he ran 12 chairs, crazy. But so he'd come in and he was like a 2-minute exam. He'd come in, what'd you find? And we'd go through and I'd tell him everything and he'd just say yes or no and then he'd be done. So I was kind of trained like that, and I came here to Salt Lake and that's just what I did. And he said that's what he really appreciated, is it saved his time from having to educate the patient on why they have a cavity, how it formed, what restoration is going to be needed. So although we can't diagnose, we can educate and we can talk about suspicious areas that you see and that it could possibly be this, and if it is this is the restoration that he'll talk to you about. And then the doctor comes in and just says yea or nay, and they really, really like that. And when you girls get out, it's very competitive, as you know right now, and you're going to be competing for a spot. So if you're competing against someone that has exact same skills and the great charming personality, this is something that may put you over the edge in a working interview. This is something that, you know, your x-rays, we always tell you, are your first impression. What you find in the exam could be your second impression and could get you the job. So I encourage you to really start looking for that in your patients in clinic and kind of having things written on a sticky so when the doctor comes in, you can say, I think there's something here, check out this surface here, so that you're kind of guiding the doctor through the mouth. They really like that. Yeah.
How are you able to do, I know that some of the stuff that we do in clinic is not usually done in private practice, so how are you able to do the probing, a full cleaning on a class 2, class 3, and an entire diagonate, all the, and you said the intraoral camera, how are you able to do all of that in 30 minutes?
You just get faster at it. Think of the first time you put on a full face of makeup, okay? If you had to put on, you had to wash your face, you had to put on your primer, your moisturizer, your blush, your mascara, your eyeliner, all that. You know, the first time you do that, it takes a while. But how fast did it take you to do it this morning when you had a big class at 9?
3 minutes.
Yeah. So you just work up to it. It's just experience.
Yeah.
You just work up to it. Wouldn't you agree?
That's a great analogy. Except for me.
Let's see. So preventative planning. So you guys all know the risk assessments sheets that you have in clinic, and you've been using those. So those are really helpful to find out how high of risk that your patients are at, and to offer certain things that can help to prevent the dental caries. And we'll talk about some of those things here. And we stress OHE, OHE, OHE all the time. That's because if they don't get it from you, they're not going to get it really from anyone else. So make sure you're educating as much as you can. You've got a captive audience there. Your hands are in their mouth for a whole hour, or here, or 3 hours. You know, you've got a captive audience. Take advantage of that and teach them specific to what's going on in their mouth. If you've got a patient that has no cavities, don't spend your time educating on cavities. Spend your time educating on something that might be more beneficial to them. If they said they're drinking a lot of soda, talk about that more. So make it customized to your patient. Okay, so a risk factor is a habit, a behavior, a lifestyle, or condition that increases the risk of a disease. So I put some of these pictures up here. Obviously your habits, your eating habits, huge. You know, if you're nibbling on stuff all day long, you know, grazing is what I call that, then you're constantly bathing your teeth in carbohydrates that can make it more susceptible to decay. Medications, what role do you think that has? Where does that? Aerostomia, yeah, it dries the mouth out, absolutely. It's not necessarily the medication that causes the decay, it's the dry mouth. Truck drivers, if someone tells me they drive truck or they tell me they sit at a desk job all day, I always ask them, what do you drink? Because most of the truck drivers, you know, they're drinking a lot of the energy drinks and they sip on it all day long in their truck, and it's constant exposure, or the secretary that sits at her desk or his desk and has constant exposure. So you want to kind of feel for those risk factors that your patient might have, so you can again tailor it to their lifestyle. If you look on page 381 in your book,
We don't bring that.
you don't bring it too heavy. Okay, I don't blame you. But Canberra, I'm not sure how they pronounce it, but Caries Management and Risk Assessment. Just take a look at that. That kind of is a guide on it. What is a high risk, low risk, moderate risk, severe risk for caries? Okay, caries management. We talked about this a little already. Determine the restorative needs of the patient. You'll want to kind of know what types of materials your doctor uses. If he prefers a PFM crown, if he likes all porcelain, if he likes the zirconium crown, if he does use amalgam sometimes, you know, there is, believe it or not, a place for amalgam sometimes. Some doctors don't use it at all, but you kind of want to be on board with your doctor and have the same beliefs as them, so that you're not talking to your patient about a feeling that the doctor's going to come and say, oh no, I don't do that, because then it's going to discredit what you just said. So you kind of want to get on board with what your doctor does. Identify areas to remineralize, so look for those white lesions, and initiate a remineralization program. There's personal fluoride rinses that they can get over the counter. There's dietary modifications you can talk to them about, and then you know, xylitol gum. We keep xylitol gum on the counter in my office so they can grab some on the way out. It's a great way to bring up xylitol, because they always say, ooh, what's this? And even our front office manager knows all about it, and she can educate them up front too.
Yes. Something I found out really exciting, also table clinic thing with Stacy. The xylitol gum, like I know you can like buy, I forget what it's called. But you
Trident has it.
It's
Yeah.
the ice cubes.
Right, so you
Oh,
can
ice
buy
breakers.
like an actual brand though that has
Oh,
Sprite.
right.
Yeah.
Right, that's what we have.
Yeah, so
The
but
little
if they just want to
packets.
go to the store, like want to pick up some gum, there's xylitol, but there's also the icebreakers ice cubes, and it has, those ice cubes have more than xylitol. The brand name is, it's icebreakers.
Has more than the spree.
It has more than Trident.
Oh.
Which I didn't know. I've always been
Okay.
chewing
I didn't know
Trident.
that either.
The ice cubes
Have more xylitol?
Mm-hmm.
And how much?
I can
Like
look it up.
0.003, so they can say that they have more, or is it? Look that up.
Those have the most of any commercial now.
Ah, good to know.
That
And they've
Spry.
got to last longer. That Spry gum, when we get that and we hand it out, but it's good for about 30 minutes, and then that's done. And it sticks to restorations too.
Yeah,
I
I
don't know why.
see.
Someone didn't think through that one. Okay, so we have some professional applications that can help with your patient patient that is at high risk for caries. Chlorhexidine rinse, when you think of chlorhexidine, you think of what? Perio. Yeah, you think of treating for perio. And sometimes even I still forget if somebody's got rampant caries, you know, the first thing I think of is Prevenant when I think of giving them something that's a prescription to help with their caries. But you can use the chlorhexidine rinse because it is effective against strep mutans, which is the initial bacteria that causes it. So if we wipe that away, then their risk is diminished significantly. So keep that in mind if somebody who has rampant caries. I can tell you we don't use that a lot on someone that just has a cat. We find one cavity every couple of years because that's kind of what overkill. This is for someone with more rampant caries. So what about Prevenant? What patient would be good for Prevenant? Yes. What about those incipient lesions that we see on the radiographs? Absolutely. But if they're just going to brush it on and spit it out, what is that going to do much for those incipient lesions? They got to get it flossed in between. So the directions for that is, you brush it on, spit it out, floss it really good throughout, but then don't eat or drink anything and just go to bed.
How effective is the floss that has fluoride in it?
Well, it's probably better than nothing, but it's not going to be better than Prevenant.
Right. So how long do you think it would take if someone was using, maybe not quite a chlorhexidine rinse, but improve the...
To remineralize?
Yeah.
I can tell you that in my office, if my doctor has an incipient lesion, if I point that out, he'll say, let's put a watch on that. So 6 months later that this patient comes in, I take a new biving of that area, and we have seen it in 6 months remineralize. I don't know how soon it happened in that 6 months, it happened in weeks, but within that 6 month period, we see remineralization radiographically. Yes?
The MI paste, is that not?
You know, I should know more about MI paste. It's not one that we push in our office or that we carry, so I think that is more for the white lesions. I know that. Do you have a rep that comes in and talks about MI paste or anything? We don't. Do we push it in the clinic really? It's mostly the Prevenant. So I'm assuming that because we push that mostly, it's probably more effective. But that is something we could look into.
They have to do MI paste plus stop for it.
Oh, really? I'm not exactly sure what the ingredient is in MI paste that makes it different than.
And what was MI16 for before the fluoride?
We have a rep come into our office.
Oh, really?
But it's like calcium, I want to say like 20 grams.
Sounds great. Sounds very scientific.
Good, right?
Sounds good. And then we have our fluoride varnishes that we offer.
Love those.
Yeah, they're so great. Some of you don't remember the day. Well, I guess you guys do have to do the tray ones, but where they just drool everywhere and then they can't eat and you don't want them to do anything so you can talk if you don't want it to come off. The varnish is great. There is the downside to varnish. You know, they feel like they need to go get their teeth cleaned after you've just cleaned it and put them on. But the fact that it is a varnish keeps it on the teeth for up to 4 hours, so they're able to leach out the fluoride for the whole 4 hours. So I love the varnish. I like it for kids. I like it for adults. I like it, for all ages. And then sealants. You guys do a whole separate thing on sealants, don't you? Should we touch more on that? Okay. The one thing I do want to point out with sealants is sealants only prevent decay if they're placed correctly. If they're placed incorrectly, they can actually cause more problems. And that's something that I didn't really, I'm sure I was taught that in school, but I didn't really pick up on that. If you just slap a sealant in there and doesn't have really good clean margins, and it's kind of lifting in an area, and you've probably seen that in patients that come in with a sealant and there's a bunch of stain around it and it looks terrible, that's at more risk because that bacteria can get in between the sealant and the tooth, but their toothbrush can't get in there. So you want to really, really make sure, I know on your LEs, some of you have been doing PEs on them in clinic, and we stress, we make sure you do the 20 seconds drying, 30 seconds drying in between, and that's just so that we get that really good seal so that we're actually inhibiting decay and not encouraging it.
I think that's where the misconception comes when people think then I don't want a sealant because they seal in bacteria.
Right. So they just have to be placed. In fact, I'll tell you in my office, I don't place sealants. The doctor does all the sealants. And he uses air abrasion and he cleans it out. He uses the drill and opens up any pits and fissures that look like might be suspicious to him even, and he just makes sure that it's all cleaned out and he places the sealant material. So, and he actually